This is a brief video on the use of the Adept Medical Clinician Arm Support. I'm Richard Douglas and I'm a practicing ORL surgeon in Auckland, New Zealand. In conjunction with engineers from Adept Medical, I have designed an arm support for use in endoscopic sinus surgery. I've been using this device regularly in surgery for 2 years and I found it to be helpful in improving the performance and comfort of my sinus surgeries. Endoscopic sinus surgery can be performed standing or sitting. Holding the endoscope and camera without support while standing means that the weight of the endoscope and camera are borne entirely by the surgeon's non-dominant arm. It also means that the endoscope is unsupported, and so the view can sometimes be less steady than optimal. I was trained to perform sinus surgery sitting. An arm board can be used to provide support, which means that holding the endoscope and camera is easier, and the view achieved is more steady. However, it is difficult to maintain a neutral spine position while sitting and operating, and many rhinologists report back and neck pain after long cases. Accordingly, I designed the arm support with the help of engineers from Adept Medical, an Auckland-based medical engineering company. The device has a padded armrest which supports the forearm. It is articulated with 3 joints that enable it to move freely in the horizontal plane. The tension on these 3 joints can be adjusted. It has a shaft and a baseboard which slips under the head cushion on the operating table. The quick-release locking device allows the height of the arm board to be adjusted and locked, and the shaft can be rotated relative to the baseboard. Here is a mock-up of my operating room setup. Note that the patient is in a reverse Trendelenburg position and that the operating screen is directly opposite the surgeon. The baseboard can be slipped under the head cushion from the side. The weight of the patient's head keeps the board in place. The arm support appears less stable in this mock-up because the polystyrene model head has virtually no weight. The next step is the key, adjusting the height of the arm board so it is the correct height from the patient's nose. The first step in the adjustment is to ask your anaesthetist to raise the operating table so that your forearm is supported and your back is in a neutral spine position. For finer adjustments, the lock can be flipped up, allowing the shaft of the arm support to be raised or lowered. Similarly, the shaft can be rotated relative to the operating table. This is important as often the table is in a reverse Trendelenburg or head-up position, and the shaft can easily be rotated so that it is kept in a vertical position. When the arm support is in the correct height from the floor and the distance between the arm board and the patient is correct, then the arm board supports the forearm and wrist in a natural and neutral position. If I deliberately lower the arm support so it is too close to the patient, you can see that I try to compensate for this by extending my wrist. Similarly, if the gap between the arm board is too long, I flex my wrist to compensate. Neither of these compensations are comfortable for any length of time, so if you feel yourself doing these, adjust the height of the arm board relative to the patient. I found that adjustments of only 1 or 2 centimeters can make a big difference to how much support the arm board provides. It's common to have to do this over the course of the case if you're working over a range of depths in the sinonasal cavity. Sometimes, if you wish to have the tip of the endoscope a little further into the sinonasal cavity, then adjusting your grip to slightly further up the endoscope achieves this goal without causing you to extend or flex your wrist. Holding the scope as close to vertical as possible reduces the torque of the camera head and makes the scope and camera unit less tiring to hold. When operating on a patient, the device is draped in a sterile sock. Mayo table drapes also work well. Whatever drape you use for this needs to be loose enough to allow the device to move. Turn the narrow end of the arm board to face you before you slip the drape over the device. I am a little unconvinced by my sterile technique, and pull the drape down so it covers the shaft lock so you can easily adjust this yourself during surgery and remain sterile. A U-drape is then applied. Usually this is preceded by placement of a head drape. The device is made from carbon fiber and plastic, so it does not interfere with electromagnetic image guidance systems. That really is all there is to it. I have chosen not to receive any payment for the design of this product or royalties from its sale. I hope that you find this device as helpful an aid to your sinus surgery as I have.